And doctors are afraid to go beyond the standard because they get sued. It's like, if I don't put that guy on a cholesterol pill, I'm going to get sued. But they don't have to be scared if they understand that if you get people to function optimally, there is no way they will get the heart attack and the cancer, or very low chance. And when you have this relationship with a patient where you're making them feel better and they can see the results, they won't hold it against you when something bad happens, because life is not that guaranteed. A doctor that guarantees is not a good doctor. A doctor that says that I have all the answers is not a good doctor, because one thing is sure, I don't know everything. One thing is for sure, in 5 years or even a year, what I do now will be different because I will have learned something new. It's okay to be honest. So I think what I'm saying here is honesty is transparency. And what we have in the healthcare system is lack of transparency, which is a cloak for dishonesty, right? You should be honest with the patient. I can treat this, meaning I can cure it, or I'll just control it for you. Okay, so we're going to talk about one of our follow-ups, and we're going to go over lab results. So the question really is, what is a normal lab? So if you have people that have normal labs, how do you know it's normal? Because what we really have is what's called a reference range. And so when we're looking at a blood sugar and the reference range is between 70 and 110, what that means is that 95% of the population fall into 70 and 110. So we call it a bell curve. And as you go higher up, fewer people are high. As you go lower down, few people are very low. So the reference range is between is that 95% of the people in that middle ground. And then what most people mistakenly say, particularly doctors, say that's the normal range. It's really called the reference range. That means that you are in the same range as 95% of the population. Now the problem with that analogy is that over the decades, the lab reports different ranges because that 95% of the population are no longer the same. They are changing, in my mind, for the worse. So they change those lab ranges, the reference ranges, and now people think, oh, these are the normal ranges now. So how is it normal now and it wasn't normal 10 years ago, 20 years ago? Let me give you an example. So if you have liver enzymes, they're really not liver function tests because the enzymes only come out of the liver when you damage the liver cells. So they should really be called liver damaged cells, but we use them as liver function tests. A couple of those examples are AST, ALT. Again, they follow that reference range. 95% of the people range between 5 and, say, 35. Now that reference range over the last 20, 30 years, because I've been a doctor for 20, 30 years, now I've seen it, that they keep changing the upper limit to 35, 45. It's gone to 50 now. Now, is it that the liver is becoming more functional? Is it because there are more liver enzyme being leaked, which is a sign of damage? Yes. So the point is that a reference range is just saying that 95% of the people where this lab got its testing, in other words, if it's in Europe, it may be different to Africa. So that's another complication that we can talk about. A reference range is really a reference of the people that they studied in a certain geographical area, and 95% of the population, by definition, has to fit in that. That's what the labs have come up with. That's what they want to do. And maybe we should change it. We should really come up with what the normal range is. And we have. So when you come to Next Health, we won't give you a normal range based on your reference range. We have developed our own normal range. What we call is the optimal range. Where would I want my liver enzymes to be? Do I want to be too low? No. Do I want to be too high? No. So what have I figured out? What I figured out is that when I look at multiple patients and I look at who's the healthier, who has the better liver, who's functioning better, and I see a pattern, and that pattern is whatever the range is, you've got to be about 50% or less, particularly for liver damage, right? So not everything high is bad, not everything low is bad. We can discuss that. But the point is that as far as liver enzymes are concerned, you want to be at 25 or less, right? Can you get to less than 20? Probably, not many people do. But it's not going to be much less than 15, should we say. And the lower limit of normal is 5. So there are people out there, but they're like the 5% of the population, right? The bell curve means that, most of the people are going to be about 30, 35. And myself too. So I can see when my numbers are healthier, it should be lower, and I can see when they're not as healthy. And then what that does is alerts me to thinking about, am I eating too many carbs? Am I not burning enough carbs? Is the liver overworking because I'm giving it too much fats, too much toxins, okay? So what is a normal lab is kind of what we in Next Health, how we rethink medicine is normal lab is our version of saying optimal labs, right? Let's talk about a normal physical, right? What's a normal physical? Okay, the blood pressure is normal, the blood sugar is normal, the cholesterol is normal. Let's just go, I'm mixing up lab data with physical findings. But for the sense of normal, my question is, what makes you think that the blood pressure is normal? There's a range. The ranges used to be 120/80 is like a cutoff. And then we used to say that that's a desirable range. And that when it used to be 140/90, that's a cutoff for being treated for blood pressure. They've decided to bring that down to say that, you know what, it needs to be treated when it's 135/85. So our middle zone is 120/80, but I know for myself that when I was younger, I was always 110/70. Now I'm closer to the 120/80, and sometimes it's just a little bit more. So if we got people between 100/70 up to 130/80, not quite treatment, those are all the so-called normal ranges. A little bit like reference range. But they're not optimal, because guess where optimal is? Below the 110/70 or around the 170. Or in our case, we have more sophisticated tools to look at the softness of the blood vessels. We call it the compliance, its ability to relax. Those are synonymous with not only lower blood pressure, but healthier blood vessels, which means healthier organs. So we started off with what's a normal lab, and I say the Next Health way is the optimal lab. What's a normal physical? I say, well, it depends on my healthy population. Again, it's rethinking medicine, and we have created our own optimal ranges, right? And so a normal physical may be normal to the average person, and this is where I would like to help educate the population that just because the doctor told you it was a normal physical 5 years ago, and he told you it's a normal physical 3 years ago, and then he told you it's a normal physical last year, and now he tells you have diabetes, like, did you just get it in that 1 year, or could it have been creeping up on you? Well, the sugar one is a little bit more tricky, but the blood pressure is not tricky at all. If you started, like I always did, at 110/70, and it crept to 118/75, I know that, there's something going on there, but still pretty good. Then it goes to 120/80, which is normal, but not normal for me, and that happened in my 40s, should we say. And then in the late 40s, it would go up a little bit more, 125/80, and that I attribute to the stress at work. Well, in particular my staff, but no, just kidding. No, so clearly if you're tracking 110/70 and you go to 115/75, 120/80, 125/85, it doesn't take a rocket scientist to figure out that something is changing, but they're all normal. That's what the average doctor tells the patient. It's a normal physical, it's a normal physical, it's a normal physical, because the tools that they have are all or nothing. Black and white, positive, negative, high, low. That is for dummified medicine, right? That's not what Next Health does. We're about rethinking medicine and looking at what the average doctor does, the latest research, and the weights, and we put it together the way it's supposed to be done, right? And so there's no such thing as a normal physical, because even in my I'll give you another example, my own children. If I measure their vitamin levels at the age of 17 and they're very low, does it take a rocket scientist to figure out it's not going to work out too good in the next 10 years for them, let alone 20, 30 years? It's not going to work out real good at all. Because when those vitamins are low, I know where it's coming from. They have a dysfunctional gut, which is not uncommon this day, because they sleep too little. They have a lot more stress. They're not putting the right foods in, right? All the things that the adults have, they have miniature versions. That's what happens. That's the price you pay when you study hard and you put pressure on yourself. But it's not good for your health. And I try to explain that to my children, that I don't need the best grades. I do need good grades, but in a balanced manner. I want you to exercise. I want you to get outside. I want you to study. Or like what we do, study on our feet. So here I am standing, because the study shows the people who stand longer live longer. And the coffee is not coffee, it's dandelion. Because I just give myself a cup a day, and after that, I would like to drink more coffee, but we know that too much is bad. You know? So going back to a normal physical, we're talking about optimal physical. Well, how do we figure out our reference range? Our reference is based on athletes that come through the door. Our reference is based on, you know, normal people with a wide range. So we know the diseased ones and what they look like. We know the super healthy ones, what they look like. So it's easier to figure out. Plus, I was my own experiment for the last 20 years. So I've seen it, and I have bad genes. So some of the things that I've told you about, they're not my fault. My gene kind of expresses it, but I have the knowledge to suppress it. So I do not have hypertension at 50. I do not have diabetes at 50. I do not have heart disease at 50. I don't have anything that what people might consider disease. However, am I optimal? That's a debate. And as far as I'm concerned, it doesn't matter where I am, I can still be better, or I can strive to be better. The more I strive to be highly functional and optimal, the more I can prevent disease. So the point about a physical is to pick up disease. Well, wouldn't it be better to pick up something or predict something in advance? Of course. And then some people think that, well, that's the kind of thing that a doctor does, and the things like nutrition and exercise and fitness are other people. And I'd like to say they're the same. Because the people that can perform at a high level, have good nutrition, good exercise, bodes very well to preventing disease. How do I know? I've studied it. Because it's only when those functions start to go down that disease starts to go up. The perfect example is nitric oxide and erections. As the nitric oxide goes down, the blood pressure starts to go up. So at some point, as the nitric oxide goes down, say 50%, the blood pressure is going up, like I told you, when I was 110, then 115, but it's not hypertension. So that's the window to say, maybe I can help push my nitric oxide up, and I do. And my blood pressure will come down, and I do. So it's really like a U-curve, or the other way is like a balance, right? So you know the reference range. We study. We look at publications. But the most important thing is to live the medicine. That means apply it to yourself. A doctor who does not have to apply his own nutrition, his own concept of physical exercise, his idea about what's ideal sleep, what do these reference range mean? If he cannot understand that, that's not a good doctor. That's just like a protocol doctor. A protocol doctor is no more than a computer where you plug in a few numbers, a few answers, and it gives you an answer. In fact, the computer can probably do a better job because there'll be less inconsistency. However, what I think is a good doctor is the good old-fashioned medicine, right? So what the most important thing is a good history, because the good history can line up with what the patient is really suffering from, and the labs can confirm it. So what the definition of a good history is, a good listener. So many times, unlike what I'm doing now, I'll just sit and listen. I had somebody that, as soon as I said, well, these foods are causing you harm, the first thing they said to me was, oh, then what can I eat? I just listened. Because I'm trying to study, I'm trying to understand their verbal response and what it really means. Not what she said. What does she mean? What she means is that, oh, I'm going to spoil my lifestyle now. And that's not a good positive attitude. However, I didn't respond. I'm listening to what they're saying. And what I say a good history is not what people say, or not how they answer my question, is what they don't say. What are they not telling me? So it takes a little bit of intuition. And the way I like to say, women have intuition in their home with the children. Well, this is my house, and I have my intuition. And when you come through my door, I know what you're saying, I know what you're not saying. In fact, with my test results, I'll tell you what you feel and how you are, and you're going to reflect and say, you're pretty close. Yeah. So what's the next step? A physical. What's a physical? Unless you have really bad disease, it's usually normal. However, but a physical is really, or begins with, good observation. What's a good observation? The good observation starts when the patient is walking into the office, walking into the room, the way they sit, the way they stand, the body language, the posture. I haven't even touched the patient. I may not even ask a single question. So that is good old-fashioned medicine, where you are listening, you're observing, and then of course the physical is, for me, well before the stethoscope goes on the body, is let me look at your eyes. Let me look at your skin. Let me look at your nails. Let me look at your tongue. Right? And so when you've done your listening and you've asked questions and listened to the answers, you've done the observation, you've examined them, and hopefully you may have even labs, how you put it together is very, very important. Because just like a computer, what we do is put all that information into a big vat. And then because we're experienced and we've been taught well, we start to use our own algorithm. So the Next Health algorithm makes us different to the average doctor because we rethink medicine because we have a big toolbox. We have so much data about normal function and so much data on the disease, which is what all doctors have, but they lack the normal function. And I live my medicine. I've got 3 times the ability to come to a differential diagnosis. When you're losing function, when you're into dysfunction, long before you have disease. So we talked about blood pressure, we talked about labs, we talked about normal versus optimal, and then I want to finish on a simple observation. What's the connection between acid reflux, gastritis, and say blood pressure? And then keep in mind, a good doctor is a good listener, good observer, and he can put it together because he's got experience to use algorithms that have been fine-tuned over the years, putting together not only diseased people, not only optimal people, but dysfunctional people. And has that doctor lived it? If you're a 20-year-old doctor, no. If you're a 30-year-old doctor, kind of. So it does take time to become a good doctor. So where am I going with this? So remember the thing I said about nitric oxide. If you don't have acid in your stomach, you can't produce nitric oxide. How many people are on acid-lowering medicine and don't think twice about it? And what did I say happens as the nitric oxide starts to go down, the blood pressure starts to go up. But they may not have ways to measure the nitric oxide. So the question really is, if I was to be able to demonstrate on a machine what's going on, that softness of the blood vessel, that way before 125, way before 130, 180, 135 over 85, do I have the technology to show people that, you know what, your nitric oxide level is coming down? And your blood pressure used to be X, now it's going up. And so the connection is that the acid is necessary to produce nitric oxide. And one of the common ways where a history is really important is, for a man particularly, even in his 30s, he's starting to complain of softer erections. That's no more than nitric oxide going down. But his blood pressure may not be that high, but it's coming for most people. Nothing is, in medicine, one thing is for sure. There is nothing that's 100% in medicine. There's always variations. In fact, I can have 2 twins that look the same, the height's the same, everything's the same. But what's inside the body is not the same. So when I give a general advice, it's general, even for optimal people. However, what I have the luxury is that I can follow these people over time and see where they're going. The trajectory getting better, the trajectory going down. So even when I know that my treatment may not be the same for everybody, but I have the luxury of adjusting it accordingly, because as you age, you do change. Your genes are different. You can have identical twins, and the treatment will be different, okay? So the connecting the dots is very, very important, because that's another way of rethinking medicine, that we don't just treat the cholesterol because that's the way to prevent a heart attack. You don't just treat the sugar because that's the way to prevent the diabetic complications. It's more than just. There's a connection between blood sugar, blood pressure, and cholesterol. And so one of the examples that I want to be able to use is that when you're talking about treating the cholesterol, right? So you put them on a cholesterol pill, and their cholesterol goes down dramatically, like 30%, maybe up to 50% at a very low dose. So when you go higher doses, you don't actually get double the results. But they're very effective at lowering the number. But once you stop the medicine, did you actually cure the problem? So in my mind, treatment means you've figured it out. You've cured the problem. And if you haven't, you've merely controlled it. In medicine, we call it management. So how many doctors tell their patient, I'm just going to control it, but I'm not going to cure it? The patient doesn't hear hear that treatment means you're curing me, doctor, right? Without being said. See, remember about words said, words unsaid, unspoken? That's one of them. That's one of the examples. And unfortunately, this is on the doctor's side. He didn't say that I'm curing you. He said I'm treating you, because as far as he knows, there's the only treatment out there. But you and I know that we can treat cholesterol. Because red yeast rice lowers cholesterol. In fact, Zocor came from red yeast rice. But if I only wanted to treat the number, I could do it with natural products. But I don't just treat the number. Because you have to understand that these numbers are not the disease. And I'll give you an example of how cholesterol doesn't give you a heart attack. But before I do that, when you stop your blood pressure pill and the blood pressure goes up, that means you never cured it. When you stop the diabetic pill and the sugar goes up, you didn't cure the diabetes. So listen, let's talk about curing versus controlling. The word treatment has been abused, misused, should we say, right? And so cholesterol, so if you have somebody that has, say, two people, identical twins with high cholesterol, and one of the twins you put on cholesterol pills and the number drops dramatically. The other one you do not put. You know what the outcome is? Assuming that they don't smoke, neither one smokes, no diabetes, no blood pressure, nothing like that. Just what we call isolated high cholesterol. So two twins, you imagine that they're relatively identical as far as average people think they are. One has blood pressure, cholesterol being treated with a cholesterol pill, and the number drops dramatically. The other one has the same cholesterol but has not been treated. You know what the outcome is? There is no difference in who gets a heart attack, who doesn't. In other words, if you treat them, the same number of people will get a heart attack. If you don't treat them, the same number of people get a heart attack. So if I had a choice, with the treatment I don't get there's no benefit of giving me treatment because there's no change in heart attack. I don't want it because all I'm going to do is get side effects. Okay? So, and then the other one is up until recently, when you lower the blood sugar in a diabetic, you never reduced heart attacks. Now, if you told the diabetic that, which you should as a physician, you say, I can treat your blood sugar and there's some benefits. It can prevent retinopathy. It can prevent nephropathy, kidney damage. It can prevent neuropathy, numbness, tingling, burning in the hands. But we can't prevent heart attack. How many doctors said that? Honestly, they haven't. Because they feel they're treating them. They are controlling the sugar, correct. But the only time that they lowered the heart attack was when you dealt with insulin resistance, okay? So insulin resistance is a new phenomena, relatively new, in the sense that we didn't put weight on it. It was always there. We didn't put a weight on it. And the way to think about it is this, that, so I'm jumping a little bit from cholesterol to, say, diabetes, is that if you have, if you eat the same, say fruit, let's be healthy, so your sugar should go up about the same way. The person that has resistance to insulin, he needs to produce more insulin to bring that sugar down. So if you keep on pumping out more and more and more and more, then you become diabetic, right? I used to think that was too simplistic. That's what the data is showing, that that's exactly what happened. But the phenomena of what's resisting the insulin is in, I wouldn't say debate, it's in process. And some of the simple ones are really good. Is that in order for the receptor, insulin receptor, to work well, and in order for the pathway connecting to the glucose receptor, so you've got like three things going on. You've got a receptor for the glucose, you've got the receptor for the insulin, and then you've got the connections. If you just give the body the right nutrients, like a vitamin D, chromium, vanadium, magnesium, vitamin B3, you find that all those connections work better and the insulin resistance goes down. It's a little bit more complicated than that, but that's a good starting point, because the number of people that we put people on high doses of biotin, high doses of chromium, cinnamon bark, magnesium, their sugars come down. And we didn't give them any medication. We didn't give them anything that directly says this is medicine for insulin resistance or this is medicine to pump up more insulin. It's just basically nutrients that help the system. The system is designed to have the receptor, the molecule, and connections work better. And it needs nutrients for that. So Now, so we covered a lot of area between, connecting the dots. And so one of the other ways to connect the dots is to say that the heart disease is very, very good, because there's so much studies on heart disease, much more or more useful than even, say, breast cancer, and certainly more advanced than say neurological, like dementia, although that's catching up. And what we're finding common is that there's something common about all these things. So you may imagine that what's common about breast cancer and dementia and heart disease? Well, that's what genetics has helped us understand, that genetics is not the solution to everything, because when you have a gene, you can't change it. So then what's the point? Well, the point is that with certain genes, you can predict what's going to happen. And then we also learned that even with those bad genes, if you know what to do to stop them being expressed, you can actually prevent the disease, even the worst of the genes. And one of those genes is called MTHFR, your ability to methylate. And when you don't have that ability, in a bad way, we call it homozygous, those people have more cancer and more heart disease. So just that should tell you that there's a connection. More cancer and heart disease, they're two different things. Maybe they are, maybe they're not, because that common ground called methylation. So if you have a genetic weakness, you've got to find a way around it. So one of the examples I tell people is that when you have a blood clot in your deep veins, we call it DVT, and we put people on a blood thinner, we assume that the blood thinner, including doctors, assume incorrectly that we're dissolving the clots. I'm sorry if I'm generalizing too much, but most doctors do. And I think even for at the beginning, I may have thought about it. But no, the blood thinners are just keeping the environment such thin enough so that blood clot doesn't get bigger and bigger and bigger and go to your lung and give you a pulmonary emboli. Just enough time for you to develop circulation around that clot. It's called collateral circulation. So if I have a defect in the methylation pathway, I must assume, and correctly, there are pathways around it to minimize it at the very least. And you may think, well, minimize it a little bit. 90% minimize. So I could have a bad ApoE gene, which I do. I can 90% control the expression of that gene. And if that's the case, then 90% of the MTHFR can be suppressed. What I mean by that, find an alternative pathway. Because what's common, and I'll give you another study that came up, which is that, you've heard of the BRCA gene for breast cancer. Angelina Jolie did a preventative bilateral mastectomy, so that if you don't have any breast tissue, then theoretically you can't get breast cancer. That's probably correct. But it's pretty dramatic. And the gene is so bad that the incidence of breast cancer and ovarian cancer is pretty high, particularly high. So Angelina Jolie did a prophylactic mastectomy. So in a breast cancer clinic, in a clinic that is full of breast cancer and ovarian cancer, you'd expect at least 1 or 2 people to have the BRCA gene. Not a single one had it, because it's so rare, thank God. Just like MTHFR, it's pretty rare, thank God. But why is it that the breast cancer, ovarian cancer patients they got the cancer without that gene? It's because there are probably other more common reasons to get cancer. And this is not written in stone, and I don't want you to assume that what I said 2 minutes ago is exactly what this is, but there is some connection, and it's our job to figure it out, which is that in that breast cancer clinic where 100% of them have cancer, 30% of them had methylation defect. So now let's go to another area of this methylation, and it's a test that we use, a technology where, even cancers methylate. They hypermethylate because there's so many cell division. They hypermethylate. And even cancer cells, some of them have to die. When they die, they release these methylated cells. And if you can pick them up, you can identify by the numbers who is at the early stage of developing cancer, long before you can see it on a CAT scan, long before you see it on a mammogram, long before you see it on a colonoscopy. Which is not quite true, because colonoscopy finds polyps, which are not even cancer. So let me take that one back. But most of the time people think if I find a CAT scan, a total body CAT scan, I can pick up the cancer. Yes, after it's already organized as a cancer, billions of cells. But as the cancers are multiplying, it's not visible. But it's shedding hypermethylated molecules, right? So So this is the point about normal, abnormal, normal physical, normal labs, normal physical, abnormal physical, technology that finds the cancer once already there. This is not good medicine. This is 1950s medicine. I could be wrong. Maybe it's 1940s medicine. But it's not new. It's like lipstick on a pig. They think that people will think that this is all modern, a modern CAT scan, a modern MRI, more instantaneous lab results. 15 minutes, your results are here. Really, that you think that is the high-level testing that comes back in 15 minutes? You think MTHFR comes back in 15 minutes? You think the lab that does hypermethylation comes back in 15 minutes? Hell no! So if you fall for that, I'm sorry. It's the fault of the medical field that have convinced you to expect a lower standard. And what we want to do is educate you. And if you think that what I say makes sense, then that's the type of medicine that is for the future. And if everybody does that, then that will be the new standard. But if everybody does the wrong thing, that's the standard we're stuck in, right? And doctors are afraid to go beyond the standard because they get sued. It's like, if I don't put that guy on a cholesterol pill, I'm going to get sued. But they don't have to be scared if they understand that if you get people to function optimally, there is no way they will get the heart attack and the cancer, or very low chance. And when you have this relationship with a patient where you're making them feel better and they can see the results, they won't hold it against you when something bad happens, because life is not that guaranteed. A doctor that guarantees is not a good doctor. A doctor that says that I have all the answers is not a good doctor. Because one thing is sure, I don't know everything. One thing is for sure, in 5 years or even a year, what I do now will be different because I will have learned something new. It's okay to be honest. So I think what I'm saying here is honesty is transparency. And what we have in the healthcare system is lack of transparency, which is a cloak for dishonesty, right? You should be honest with the patient. I can treat this, meaning I can cure it, or I'll just control it for you. It's the lack of transparency, lack of honesty that has slowed down the progression of curing dementia, cancer, heart disease. Because if you told the patient that I'm only controlling it, he or she would have options to find alternative pathways. Even when you have bad genes, which is not many people. In fact, I can tell you honestly, most people that have the heart attack, the stroke, the diabetes, they don't have any genetic weakness. They created it themselves. Now, you may think, oh my God, that's such bad news. I created all this problem and there was no good reason for it. No, not so fast. I've got good news for you. If you don't have the bad genes, it's so easy to reverse it. I know, because I have a bad gene. It's so hard, but it's still possible 80% of the time. Maybe I can make it 90% of the time. Maybe 100. That's what I want to do. I want to make it 100. I do not ever want to get a stroke. I do not ever want to get a heart attack. I do not ever want to get diabetes. So the only answer is if I ever live to be 80, 90, then I'll come back and tell you that, you know what, I can control it 100%. But until then, I'm an honest doctor. I don't think anything in medicine is 100%, so I won't want to believe that. All I'm going to do is do my best. But so let me just finish on what I just said. If you have bad genes, it's not the end of the world. It's not your destiny. There's a common phrase that's coming around. I hope it catches on because it's true. It should give you hope. If I tell you that most of the people where I see, they don't even have the bad genes. Why do they have it? They created it. But those are the easiest ones to treat. So when someone comes through the door and has acid reflux, I can treat that so easy. When someone has blood pressure, they come through the door, I can treat that so easy. I have so many objective data to show you. When someone has blockages, stents, even had a bypass, I can fix that. It's so easy. Now, don't come to me after you get the cancer. I'd rather you came before the cancer. But let me pick it up before it comes. So I can engage the methylation. I can engage, reducing the inflammation, oxidation. I can optimize your immune function. If I do all that, the chances are good for you. But no guarantees, but they're good for you, right? So covered a lot of ground. And the bottom line, these are examples of rethinking medicine. These are examples of all the information out there. As a physician, I have the ability to put in my own algorithm. I should not have to be told that if you have cholesterol, you should be on medicine, because I showed you studies to show if you just have isolated cholesterol, it's useless being on medicine. But if you have cholesterol and blood pressure and diabetes and you smoke, you might get some benefit by taking medicine. But you need to also control the sugar and stop smoking. And you may imagine that, this is another example which will shock you. So let's look at a really clear-cut situation. High cholesterol scares everybody, right? Oh my God, I got to get heart disease. My doctor's always telling me to take the pill. Fine. If you have blood pressure, you probably should. There's evidence that it's better. So let's look at the worst case scenario. Blood pressure, cholesterol, blood sugar, smoking, I don't exercise, right? Yeah, okay. So as a good doctor, not me, but all those good doctors out there, they treat the blood pressure, the blood sugar, the cholesterol. They tell you to stop smoking, and luckily they made them, stop smoking. You may imagine that they will reduce the risk of a heart attack by 100%. No, okay, you know, I already gave you a clue, nothing's 100%. Well, say 80%, that's pretty damn good. No, how about 60%? Not a chance in hell. Less than 50% for sure. You know what the risk of having a heart attack after you control all those things, the worst of the worst, a 25% reduction. That was old news. It's probably less effective now. So all I want is transparency and honesty. Tell the patient you're treating every possible parameter, but I cannot give you 100% reduction in heart attack, not even 50%. I can give you 25%. That's okay. Then you should look for the 75%. That's easy. Understand nitric oxide, understand inflammation, understand oxidation. If you know what they are, how to measure it, and fix it, you will prevent the heart attack, the stroke, the diabetes. So there's hope, but I was being sarcastic. It's not a good doctor, because that doctor who's been doing the same thing for the last 20 years, now I can say that. I've been a doctor for more than 20 years, 25. I can say that they're still doing the same thing. It's like putting lipstick on a pig. You're doing the same thing and expecting a different result. It's called insanity. The one thing guaranteed about medicine is that the medicines don't change, but the people are getting worse, so the results are getting worse. So what I told you was a 25% reduction. That's old study. New studies will probably show that fewer people are being benefited because the patients are getting more diseased, because they're not being told disease isn't when you just get your blood pressure. Disease isn't when you just get your high cholesterol or the blood sugar. Disease comes many decades beforehand, probably in childhood, just like my own children have nutrient depletion, which tells you they may get insulin resistance. I know they have it, right? So my point is that at least I know what's hard is, can I make them change? So maybe making a video like this and they watch my video might be a way where they may understand that what daddy's saying, there's a reason for it, but at home, nobody respects the daddy at home. So, but my point is that I'm going to work hard at not only communicating to the people, I want to practice it in my office. I want to get people excited by showing them the great results, and maybe my kids will get excited.